Hello, everyone. So I am Vidya Krishnan. I'm a professor of medicine at Case Western Reserve University and pulmonary and critical care and sleep specialist. I do eConsults for Arista MD and pulmonary and sleep as my two specialties. But today we're going to talk about understanding COPD, a pretty common consult diagnosis that I get, a common disorder that you probably see a lot in your practice, and just reviewing some of the basics for diagnosis and management of COPD. To start with a definition, so COPD is a progressive lung disease characterized by airflow limitation and breathing difficulties. It's typically caused by long-term exposure to irritants, most commonly tobacco smoke, but can also be due to air pollution, chemical fumes, and dust. COPD generally encompasses two main conditions that we're most familiar with: emphysema, which is really a radiographic diagnosis where there's damage to the air sacs in the lungs, and chronic bronchitis, which is more a clinical diagnosis characterized by inflammation of the bronchial tubes, resulting in productive cough chronically. But we know that there's multiple other phenotypes of COPD. Uh, COPD asthma is an overlap syndrome that we see commonly with patients who have fixed obstruction in their pulmonary physiology, but also have significant improvement of their bronchospasm with bronchodilators. We have patients with a COPD and obstructive sleep apnea overlap. In these patients, they have the obstruction that comes with COPD, which is an expiratory obstruction. And then at nighttime, when they're sleeping, they also have sleep apnea, which is a condition that obstructs the upper airway and causes inspiratory obstruction. So during sleep, they have inspiratory obstruction and expiratory obstruction, which leads to increased CO2 levels and hypoventilation. Another phenotype that we see is chronic asthma. When it's chronic and severe, it can cause an irreversible obstruction that is clinically very similar to other forms of COPD. So the 2024 GOLD guidelines, GOLD standing for the Global Initiative for Chronic Obstructive Lung Disease. Uh, you'll see many of their slides in this presentation, but they proposed a taxonomy for COPD to address these different phenotypes. They have the genetically determined COPD or COPD-G, which is associated with alpha-1 antitrypsin deficiency and other genetic variations. There is COPD due to developmental issues, COPD-D, which can happen early in life with premature birth or cardiac surgery, open chest surgery during childhood. Environmental COPD is cigarette smoking, which is by far the most common that we see, but it not only includes tobacco smoke, but also vaping and e-cigarettes and cannabis smoking. And we've identified biomass and pollution exposure, COPD-P, as another major cause of COPD with exposure to household pollution, ambient air pollution, cooking with gas stoves, wildfire smoke, occupational hazards fall under this. COPD due to chronic infections, such as childhood infections, tuberculosis, HIV, the COPD asthma type that I mentioned earlier. So that's a nice framework to think about the different types of COPD. When we're trying to look for new diagnoses, patients with COPD, some of the typical symptoms that we might encounter are things like chronic cough, shortness of breath or dyspnea, sputum production, wheezing, fatigue, or chest tightness. But there might be some less typical history features, symptoms, and signs that we might encounter in patients with COPD, like frequent respiratory infections. You can get swelling in their ankles or feet, so lower extremity edema. There can be unintentional weight loss, particularly with the emphysema type of COPD, cyanosis, or sort of that bluish hue in their extremities and fingers. Clubbing of the fingers is listed here, but it's generally a rare manifestation of COPD without other complications. Um, Sleep disturbances uh, due to symptoms, and then depression and anxiety, which can be associated with many chronic medical conditions. So, how do we diagnose COPD? You know, history is is the most important thing that we do, in our practice, right? Is to get a good history, and then we use that physical examination then to support or refute what we're thinking about in our differential diagnosis after we take that history. So we're looking for that exposure history to smoking. A family history of COPD may suggest a genetic predisposition. uh, Looking for that smoke exposure at home from home cooking and heating fuels. This can be seen in the US. It's more common outside of the US, but we are finding, that home cooking and gas stoves can be environmental exposure. Occupational dusts, vapors, fumes, gases. That's why it's important to take an occupational history as well as an environmental history. On exam, you might see somebody who is barrel chested, really with hyperinflation of their lungs. They might have this tripod stance where they're leaning over to sort of put their respiratory muscles in the most advantageous way to breathe and take deep breaths using their accessory muscles. You might hear decreased breath sounds in patients with emphysema just because they are so hyperinflated that the actual air exchange is pretty minimal. You may or may not hear wheezing as well in patients with COPD. But really, to diagnose COPD, you absolutely need the pulmonary function tests. You need spirometry, uh, and preferably with bronchodilation, to identify patients with a fixed obstruction. And I'll show you what that looks like. Other pulmonary function tests that may be helpful in the diagnosis of COPD are the lung volumes, to look at the total lung capacity, and the residual volume to look for air trapping and hyperinflation, and the diffusion capacity of oxygen, the DLCO, which would be decreased in many forms of COPD. But here is an example of why the spirometry is so important to diagnose COPD. On the left-hand side, you have normal spirometry, and this is the volume time curve. So volume on the y-axis, time on the x-axis, and the maneuver is having the patient start from total lung capacity and then exhale as quickly as possible. And when they exhale from time zero, they have this quick increase in exhaled volume until a point where they plateau. And then there's no more air that's left in the lungs that can be exhaled. What is left in the lungs is residual volume at this point. So the volume of air that's breathed out in the first second is called the FEV1. And then the total volume that's breathed out is the FVC, the forced vital capacity. So here we have some what normal-ish numbers might look like, with a FEV1 to FVC ratio around 80% or zero point 0.8. So about 80% of the lung volume is exhaled with a forceful exhalation in that first second. In patients with obstruction, doing that same spirometry maneuver, they are going to exhale, but they may not be able to exhale as forcefully. So it's a slower uptake in the volume. It might take longer to exhale completely. So the point at which they attain that plateau of fully exhaled vital capacity of their lung, that forced vital capacity ends up being much later. In this case, it's even beyond 6 seconds that it takes for this patient to exhale completely. So then the FEV1 is decreased compared to normal, and the FEV1 to FVC ratio is also decreased. This decreased ratio is what we use to diagnose obstruction, obstructive ventilatory defect. When you give a bronchodilator and there is still obstruction after you give bronchodilator, that's confirmation that this patient has a fixed obstruction or chronic obstructive pulmonary disease. That diagnosis of COPD is obviously very important for patient care. It's also very important in documentation. In patients who do have COPD and recurrent hospitalizations, there's a significance to having recurrent hospitalizations due to COPD and being able to find those patients to target and optimize management. When you don't know that they have COPD, you don't have those spirometry tests, the possibility is there that they may have a condition other than COPD. And that's where you want to think of this differential diagnosis of what else patients could have when they present with similar features. So, COPD, we talked about how it might present. Asthma may have a variable airflow obstruction. Typically, their symptoms vary from day to day, from time to time. It's worse at night in the early morning hours compared to the rest of the day. There's usually triggers like allergies or exposures that the patient has. Often occurs in children, and there's often a family history of asthma. Congestive heart failure is another condition that can often be confused with COPD. But in this case, you'll have a chest x-ray that might show a cardiomegaly or pulmonary edema. The pulmonary function tests would actually show more of a restriction because of the pulmonary edema as opposed to airflow obstruction. Bronchiectasis is another condition that can cause an obstructive pattern spirometry, but this is a case where the airways are pathologically enlarged, and so there's pooling of secretions in the lungs, and that predisposes to recurrent infections. So there's large volumes of purulent secretion, sputum, is commonly associated with bacterial infections, and the chest x-ray and particularly high resolution CT will show these bronchial dilations. Tuberculosis is an infection that can affect any age. The chest x-ray may actually show infiltrates during active tuberculosis. You'll need microbiologic confirmation for this, and there are certain areas that obviously have a very high prevalence of tuberculosis that you would want to think of this more commonly. Obliterative bronchiolitis is seen a little bit less frequently. It can occur in children, but it's more often seen in patients with chronic um, uh, sequelae from bone marrow transplant or lung transplant. And it's seen on high resolution CT. On expiration, they show these hyperdense infiltrate areas. And then diffuse panbronchiolitis would be another condition where it's predominantly seen in Asian patients, most commonly males and non-smokers. Almost all of them present with chronic sinusitis symptoms, and their chest x-ray and CT scans will all show these opacities and hyperinflation. Okay, so now that we've confirmed the diagnosis of COPD, to gauge the severity of the COPD, we're looking at this assessment tool, which uses the FEV1 from the spirometry to look at the gold level of severity. So an FEV1, once you know that they're obstructed, their FEV1 to FVC ratio is low. Gold diagnosis, this says less than 70%. Then the FEV1 dictates the severity by the gold standard, with FEV1 greater than or equal to 80% of predicted. It's considered gold stage 1. 50 to 79% is gold stage 2. 30 to 49% is gold stage 3, and less than 30% is severe. It's gold stage 4. But another way to categorize COPD that we're finding clinically more helpful is this ABE system, where we look at the patient's symptoms using either the MMRC or the COPD assessment test, CAT score, and their exacerbation history. So the exacerbation history is simple. It's at least 2 moderate exacerbations that require steroids, or at least 1 that required a hospitalization is considered severe, or 0 to 1. Moderate exacerbations or no hospitalizations would be less severe. And then let me show you the MMRC is a dyspnea scale that looks from grade 0 to 4 based on what they're able to do with exertion. I only get breathless with strenuous exercise is a MMRC 0, whereas I am too breathless to even leave the house, or I'm breathless when I'm just dressing or undressing, is the most severe, MMRC 4. The CAT assessment similarly has symptoms of dyspnea that patients can describe how severe their symptoms are, whether they're coughing all the time or never. Are they producing phlegm? Do they have chest tightness? Do they get dyspnea with exertion? The maximum score here is 40, but a score of greater than or equal to 10 or an MMRC score of greater than or equal to 2 would be considered severe. So then, based on the exacerbation history and the symptoms, we can categorize a patient as group A, B, or E for their COPD. This classification for patients with COPD is important when we think about the management of these patients. So across the board, we are recommending smoking cessation counseling for all of the patients. This is obviously a big risk factor for why they developed COPD. Some patients, despite having these severe symptoms, can still have the addiction to the nicotine and tobacco, which is a serious problem for patients. And so, really addressing their addiction and helping them with cessation is one of the most important interactions that we can have with these patients with COPD. So, the GOLD guidelines give us this strategy to help patients quit. First, obviously, is to ask, systematically asking them at every visit whether they're smoking. I even ask patients who have told me they quit smoking. I'll ask them every appointment in case they've restarted again. Advising the patient, strongly urging them to quit, and looking at the reasons why from a quality of life perspective as well as their larger health perspective. Assessing their willingness to quit, determine their willingness and rationale for a patient's desire to make a quit attempt. Uh, will they want to quit in the next 30 days? And that can help you gauge how potentially successful they'll be. Assisting the patient when they're willing and able to quit, aiding them by prescribing pharmacotherapy. Varenicline is one of the medications that has been proven to help keep smoking cessation the most successful. We also use bupropion and all of the nicotine replacement therapies. And then arranging for follow-up, said, to reinforce these ideas is important for patients. The next part of COPD management is the bronchodilator therapy. Some of the medication options we have are short-acting and long-acting bronchodilators. The short-acting bronchodilators, abbreviated SABAs and SAMAs, are medications like albuterol and ipratropium. They can be given as metered dose inhalers or as nebulized treatments. The inhalers tend to be uh, more compact, readily available, but these medications are used for the quick relief of acute symptoms. We use the longer acting therapies for maintenance therapy. So long-acting muscarinic antagonists like tiotropium or umeclidinium can be used for maintenance therapy. When we prescribe a LAMA, you want to stop the short-acting muscarinic antagonist because you don't want to overdose a patient with muscarinic antagonist effect. So when you prescribe a long-acting muscarinic antagonist, you would stop their ipratropium or their duonebs, Combivent, whatever it is that contains ipratropium. There are combination inhalers, which really helps patients with adherence to therapy. It's much easier to use one inhaler than to remember all the different inhalers that they have. So combination, a LAMA with a long-acting beta agonist is the next tier of therapy that we would give a patient with COPD. Um, the combined bronchodilators are effective in management. And then there's a triple therapy as well, which includes a LAMA, a LABA, and an inhaled corticosteroid, which is really reserved for the most severe COPD patients. And I'll talk a little bit more about that component of the inhaled corticosteroid, like budesonide or fluticasone. In patients who have exacerbations of their COPD or just very difficult to manage COPD, we'll use oral systemic corticosteroids. Um, and then in patients that are difficult to control, we have additional medications in our armament now. Things like roflumilast is a PDE4 inhibitor that is used to reduce inflammation in the airways for patients with severe COPD. And chronic azithromycin is sometimes used in patients with a more chronic bronchitic phenotype of COPD when they have frequent exacerbations. But going back to that framework of categorizing the patient's severity of COPD as A, B, or E, so we can use in group A, these patients can be managed adequately with short-acting bronchodilator. If they have 0 to 1 moderate exacerbations in the previous year and no hospitalizations, and they have minimal symptoms for their COPD, just a short-acting bronchodilator is probably sufficient. They may need a single agent, like a long-acting muscarinic antagonist with a rescue inhaler. That's group A. Once they start to have more significant symptoms is when you want to add on additional maintenance therapy. This is when the LAMA-LABA combination is helpful. As a single inhaler, it's more convenient and more effective even than multiple inhalers. And then still prescribing the albuterol as the rescue inhaler. And then in patients who either have frequent exacerbations or hospitalization, or have severe symptoms, or have both, they're definitely going to need at least the combination of the long-acting beta agonist and the long-acting muscarinic antagonist. And this is when you would consider adding on the inhaled corticosteroid. And we know that the patients who do best with the inhaled corticosteroids are ones who have significant airway inflammation. When their blood eosinophil counts are more than 300, I'll also add perhaps when they have a significant bronchodilator response on their spirometry testing. These are the patients that have maybe a little bit more of an asthma-like component, and the inhaled corticosteroid could be beneficial there. The reason why I single out the inhaled corticosteroid is that there are data to show that the inhaled corticosteroid in patients with COPD can increase the risk of pneumonias. So it seems counterintuitive. Why would you want to increase the rate of pneumonias? This is why I'm saying it really should only be reserved for those patients with the most severe COPD when you're maximizing therapy and you still need something additional to help them with their airway inflammation. And it's those airway patients that have proven significant airway inflammation that do best with the inhaled corticosteroid. There are some lifestyle modifications that should also be considered in patients besides the smoking cessation that we already talked about. Pulmonary rehabilitation can be very helpful for patients with symptomatic COPD. Generally, insurance will cover it for moderate to severe COPD. It's a comprehensive program including exercise training, nutritional counseling, and education to help manage their COPD holistically. It's at our institution, it's a series of 8 weeks, 3 times a week. They are going in a monitored setting to do their exercise programming as well as get the nutrition and educational counseling that's tailored to their needs. The nutritional support is helpful, particularly in those patients with pulmonary cachexia or severe weight loss that's unintentional, often because they're working so hard to breathe that their caloric expenditure is increased by their respiratory system, as well as additional inflammatory and metabolic increases. So focus on nutrition is important uh, for their overall health and addressing any malnutrition, especially in advanced stages of COPD. I have some patients who are so motivated, they've graduated from their pulmonary rehabilitation, that I really push them to exercise regularly to their limit, right? Engaging in physical activity is going to be helpful for their overall health and their endurance and strength, but it also will maintain their quality of life and their exertional tolerance. And for some patients who have severe COPD, teaching breathing techniques can also be very helpful. And this is also part of what they do in pulmonary rehab. But some patients figure it out on their own. But some people need a little assistance in things like pursed lip breathing, where they keep their mouth closed a little bit longer than we would otherwise when we're breathing to keep the pressure in the airway and cause a little bit of positive pressure to keep the airways open. Techniques like this and diaphragmatic breathing can help ease the symptoms of shortness of breath and dyspnea. Oxygen therapy has been shown to be helpful in a subset of patients with COPD. So, the long term administration of oxygen increases survival in patients with severe chronic resting arterial hypoxemia. This is very well supported by evidence. But in patients with stable COPD and only moderate resting or exercise induced arterial desaturations, the prescription of long term oxygen does not lengthen time to death or first hospitalization, or provide a sustained benefit in health status, lung function, or 6-minute walk distance. Um, the resting oxygenation at sea level does not exclude the development of severe hypoxemia when traveling by air, which is a consideration. Ventilatory support is also a consideration. Non-invasive positive pressure ventilation, that NIPPV, which is also sometimes called bilevel pressure support. Um, it may improve hospitalization-free survival in select patients, particularly those who are CO2 retainers, who have pronounced daytime hypercapnia with an arterial CO2 level that's greater than 53. Um, in patients with severe chronic hypercapnia and a history of hospitalizations for acute respiratory failure, long-term non-invasive ventilation may be considered and could be helpful in reducing hospitalizations. So the general guideline for prescribing oxygen for COPD patients is arterial oxygen level of less than or equal to 55 millimeters of mercury on an arterial blood gas, or an oxygen saturation of less than 88% at rest, or an oxygen level that's greater than 55 but less than 60 with evidence of right heart failure or erythrocytosis. In these patients, it is helpful to prescribe supplemental oxygen, keeping the oxygen saturation greater than or equal to 90%. I'll add a caveat there that in patients who are also hypercapnic, you do not want to over-oxygenate these patients. So when you're giving supplemental oxygen, the target should not be to increase the oxygen saturation more than about 92 or 94%. You would want to recheck in 60 to 90 days if the supplemental oxygen is still needed and if the prescribed oxygen levels are effective or if they need to be modified. The GOLD guidelines do make a point to identify which interventions that we give that are actually effective on mortality for these patients with COPD. So, in symptomatic patients with severe exacerbations, this triple combination therapy in a single inhaler, as compared to just the dual long acting bronchodilator therapy, did have a significant relative risk reduction in these two trials. But again, only in the most severe patients and symptomatic. Um, in the non-pharmacological therapies, things like smoking cessation, pulmonary rehabilitation, the long-term oxygen therapy in those patients who qualify, non-invasive positive pressure ventilation in patients who qualify, and then lung volume reduction surgery have all been shown to have uh, benefit on mortality in patients with COPD. Going back to the point about initiating the inhaled corticosteroid therapy. So I, you know, told you that the inhaled corticosteroid add-on to the maintenance therapy can increase pneumonia risk, but it also has a mortality benefit in those patients with severe symptomatic COPD. So the factors to consider when you're balancing those two, the patients that would strongly benefit from the inhaled corticosteroids are those with a history of hospitalization for COPD, at least two moderate exacerbations of COPD. So they're group E. They have blood eosinophil counts that are high, greater than or equal to 300, absolute eosinophil count, or they have a history of or concomitant asthma. These are the patients that would benefit most from inhaled corticosteroids. Those who may benefit are those with one moderate exacerbation of COPD per year and or a blood eosinophil count of 100 to 300 cells per microliter. And the ones who may not benefit from it are the ones who do already have recurrent pneumonia that don't have a significantly elevated eosinophil count and or they have a history of mycobacterial infection, um, where those patients, that mycobacterial infection could even be exacerbated by steroids. I mentioned it in a previous slide, but procedures are also available for patients with COPD, and these are really ones that should be referred by a specialist. But endobronchial valve procedures have become not very, but much more common for patients who have particular areas of their lungs that seem more hyperinflated. Lung volume reduction surgery is also available specifically for patients who have predominantly upper lobe involvement of emphysema. Bulectomy is a possibility for patients who have bullae in their lungs. And all of these procedures would really require mapping out the severity of their disease by chest CT to look at the pattern of involvement of their lungs. And then the final last resort is lung transplantation. Double lung transplantation is generally a last resort in patients with severe COPD that is not amenable to these other management or treatments. And then finally, I would be remiss to not mention vaccinations as a cornerstone for prevention of infections in patients with COPD. So the GOLD guidelines also recommend that all patients with COPD should get their annual influenza vaccine, which is the season has started, the pneumococcal vaccine, and the there are different types of pneumococcal vaccines, but being up to date on those. COVID-19 booster vaccines are available and also are going to be important in fighting off future severe infections. The respiratory syncytial virus, RSV, is another vaccine to consider for COPD patients. And then the tetanus, diphtheria, and pertussis, Tdap, is important to prevent infection from pertussis. I added shingles on here, although that's not part of the COPD GOLD guidelines. It is also indicated in many of the patients with COPD, particularly above the age of 50. And that's really my review of the management of chronic COPD. And I am happy to take any questions at this time.
Thank you so much, Dr. Krishnan. We did receive a couple of questions. Once again, everybody, if you do have any questions, please feel free to type them in our chat box as we will be answering them now. But the first one we received is spirometry, PFTs, a must to diagnose COPD, or is long-term smoking history enough to label them as COPD without any symptoms of cough or SOB?
That's a great question. So COPD, by definition, is obstructive ventilatory defect on spirometry. So you must have spirometry in order to make the diagnosis of COPD. The long history of smoking is highly suggestive of COPD, but as I was alluding to, there are other things that may be caused by smoking that can mimic COPD, things like cardiac disease, which can be increased in patients with smoking and also cause shortness of breath. There are interstitial lung diseases that are more common in patients with smoking, like RBILD. I'm going to throw out a whole bunch of letters there, but interstitial lung diseases could also very much look like COPD in the sense that it could cause dyspnea. So spirometry is definitely needed. Emphysema, that term, is a radiographic diagnosis. You don't need spirometry to diagnose somebody with emphysema in particularly, but you do need some sort of imaging, chest x-ray or chest CT, to make that diagnosis.
Thank you so much. And the follow-up on that would be, how do you diagnose, or how do diagnostic approaches differ for patients with COPD who are non-smokers?
The diagnostic approach would be generally similar, but you start to have to think of all of those phenotypes that we talked about early in the talk. That is there something else that's contributing to the patient being at high risk for developing COPD? Do they have other exposures? The gas stove, like I said, is something that is coming into our consciousness as being more of a risk factor, but environmental inhalations, fumes, gases, what is their occupation? Do they have a family history of COPD? And maybe they have a genetic predisposition to it. So all patients who have COPD, I didn't mention this, should get their alpha-1 antitrypsin tested at least once. Because those patients who have alpha-1 antitrypsin deficiency can be treated with IV alpha-1 antitrypsin infusions. So that might be one difference in that case. But it's really identifying what is their predisposing factor. If it's genetics, then genetic counseling may be warranted for the rest of their family members. HIV is a condition that we know causes premature COPD. So even insignificant smoking history or secondhand smoking history is sufficient to cause COPD in those patients, but we would start looking for these secondary comorbid conditions.
Thank you so much, doctor. Our next question is, how often should you reassess your patient's treatment plans?
Oh, I like that question. It's really, I think, tailored to patients. In general, you should see a change in their symptoms in 3 to 6 months. So that's usually my time frame that I will reassess them, either seeing them back in clinic, or if I want to prove to myself or them that their spirometry is improving, just doing the simple spirometry portion of the PFTs would be helpful to document that. Um, you don't necessarily have to do it for every minor change in their therapy, but it is helpful to look at the trend of their FEV1s over time to see what therapies were helpful and which ones were not.
Thank you so much. Our following question is, how do you approach medication adherence with patients?
Uh, so you have to be realistic. I think, the intention to treat is what we're looking at. So even if we prescribe an inhaler to use daily, chances are, a good patient who is adherent to their medications may take it 80% of the time. I think that's being realistic, but really, trying to reinforce that the more that they use their medications, the way that they're prescribed, the better they will feel, the better controlled their COPD will be. It is known that multiple medications causes more non-adherence. So keeping the regimen as simple as possible, you have a more likely chance of patients following the recommended plan. So that's why those combination inhalers for the maintenance inhalers are so helpful because they're efficient, but they're also convenient for patients to use. Uh, we have to balance that, in real world with cost too. And some of the single agent inhalers are more, they're cheaper and more affordable for patients than the newer combination inhalers. So I really encourage you to work with your local pharmacy, or if you have, if you work in a healthcare system, the pharmacy within your system or the local pharmacies really to find out which inhalers are the cheapest and which ones can be the most affordable for patients.
Thank you so much. And the last question that we have received is, when treating in the primary care level, what are the warning signs that indicate a need for urgent care?
Yeah. So if you're seeing the patient in clinic, obviously if they're in distress, if they're not able to speak, if they are tripoding, like I said, and using their accessory muscles more than usual. Well, I won't declare that. So just using their accessory muscles or tripoding, I think those are concerning. If their oxygen saturations are lower than expected on their normal amount of oxygen supplementation that they use, if you have access to getting an arterial blood gas, increases in their carbon dioxide levels and acute respiratory acidosis would also be alarming and reasons to have the patient be seen in a more acute setting, and they might need to get treated, hospitalized even for a COPD exacerbation. I think the difficulty comes with the really severe COPD patients who sort of always have a little accessory muscle use. They always have a little wheezing. And this is why documentation is so important for primary care providers so that, urgent care providers, if they're seeing a patient for the first time, they can look back and see what the patient sort of looks like at baseline. Um, I will say patients generally also know themselves pretty well too. And at some point with these symptoms, they tend to know when they're in an exacerbation. I trust the patient when they're telling me they feel that sensation.
Thank you so much, doctor.